I'm James Harvey, and I want to welcome everyone to our session on a minimalistic approach to TAVI using the SavvyWire. We have an excellent panel of people from and some speakers from around the world, so looking forward to a very good discussion. All right, so I'm James Harvey. I'm an interventional cardiologist. I also serve as the Chief Medical Officer for the WellSpan Health System Heart and Vascular Service Line. It's a privilege to talk about a standardized invasive hemodynamics to facilitate lifetime patient management. So these are my disclosures. I'm going to start with a question on everybody's mind. Why are we doing this at 6:30? I don't have the answer to that, but it's a very good question. So let's talk about TAVR and the importance of hemodynamics. So hemodynamics. So I'm not going to get into the debate of the observed. We know there's discrepancies between echodoppler and invasive. Now, if you want to talk about pressure recovery, this has been a fairly age-old debate that if you looked at the late breakers, et cetera, that wasn't resolved at this conference. So, but we do know that there's observed discrepancies, and I think few would argue that the gold standard is invasive measurements. That being said, they take time to set up. You need wire and pigtail exchanges. LV pressure is not monitored constantly during the procedure. Have we proven we can do that? The answer is yes. Would it be ideal to have it? The answer is yes. Large amplitude LV pressure creates artifact in fluid-filled tubes. Is this true? It is. Is it true all the time? No. Does it impact some of our cases? The answer is yes. But is it always there? No. We know that assessing and treating moderate aortic stenosis looks more and more like it's going to become important in the future. And I would argue the most important one is we're treating lower risk, aka younger patients. They're being treated, which means that good enough is not good enough anymore. We have to be great. I don't know if you remember the movie The Princess Bride. I've been lucky enough to say I started doing TAVRs about 12 years ago, 13 years ago, and the character in Princess Bride said, he's not dead, he's mostly dead, right? And that was kind of like the patient subset, get him out alive, because really we had a really sick patient population, but our patients are now lasting 1, 2, 3 decades after TAVR. Good enough is not good enough. So what about the SavvyWire? What about hemodynamics and workflow? You can see here, and I won't belabor this, but we have the optomonitor interface with an optical connector that can be connected or disconnected anytime. If you use the OptoWire 3, it's very similar. Hemodynamic pressures, gradients are always available without exchange at baseline, after pre-dill, during partial deployment, if that's what you want to check during self-expanding valves, post-dilatation, and at the end. You have accurate live diagnosis the entire time, gradients, whether you want mean, peak to peak, max. If you want to assess aortic regurgitation, most of us are good at looking at the AO, the diastolic pressure, and the LVDP, and you can tell right then whether or not that you have significant aortic insufficiency instantly. So the display is actually, as you can see, quite favorable, and you have whatever setups you prefer as an operator, whether you're looking at, one of several LVDP modes versus looking at systolic, diastolic. Again, you can see that you can get whichever instant recording or instant monitoring of peak to peak, mean, whatever it is that you need to use there at the time or that you prefer. So again, saying the same thing, immediate pre and post comparison without device exchanges. So he's covered that. So what do we know about it? Well, I don't think anybody would argue that invasive hemodynamics, like we said, are the gold standard. But you still want to compare this, right? And so actually, Philippe Généreux and his team did a nice study looking at comparing OptoWire 3 and our TAVR algorithm, comparing pigtail measurements, right? And what did we find? Well, not surprising, if you compare the OptoWire or the SavvyWire versus catheter versus what we consider the gold standard, whether you look at TTE, TE, any other comparison, there is no comparison better. There's no better correlation than options than LV pressure wire and cath. And I would actually argue that we're going to have to question, so is cath truly the gold standard? I think actually most of us, if you understand the physics behind it, would argue that this pressure wire is actually the gold standard. But either way, since we've historically used cath as the gold standard, I think we can at least agree that there's no greater technology that we have to assess that correlates better to cath than using a SavvyWire or this pressure-sensitive monitor. So similarly, if you look, when you compare the two in invasive gradients, I won't belabor it, but just simply looking at, on average, you have a 1 to 2 millimeter difference in mean gradient. Which one's right? That's a good question. I would argue that the wire is, but either way, I think we would agree, again, that we've shown that, that they're essentially interchangeable. So I'm an interventionist. I like showing cases. There are a couple of places that we found this to be, particularly the hemodynamics, the hemodynamic monitoring that I found is to be very valuable. This is a patient that we felt was appropriate for a balloon expandable valve. They were right on the cusp between a 23 and a 26. For a couple of reasons I won't go into, we felt a little more comfortable using a 23. And it's not often, but I've had times that I'll put in the lower of the valves and I'll find out, is this really right? Is this where I want to, or do I need to post-ill this? I really want to get the right hemodynamics here because you sure hate to see that gradient at 22 the next day when you check on your surface echo. So you can just see there, nothing special about the three-cusp coplanar view. You can see there, even with the wire in, I actually prefer oftentimes to do, to fill it while pacing just because you get a little bit better filling. You can see that with the wire in. So just assessing there, and I will comment that I think I'm one of the last holdouts to LV pacing. I did just great with an RV pacer. I didn't like it, didn't believe it, didn't need it. And then this wire came out after using it for not too long. We realized that not only was it dependable, it was more dependable. So you can see here, obviously, anyone who's ever been in a balloon expandable valve knows that that's the one part that can really get you is if you lose capture. So and this is actually proven now to have the best lack of capture loss. So just looking here, and you can see how in real time, we can keep it, you have the ground on the back, and we can have a real-time pressure monitoring the entire time. This is actually our setup right here. And this was that case. This was one of the first times we'd used this, actually. You can see here that we could tell very clearly that the 23 valve was perfect. We didn't need to add anything. And this is actually real time also looking on the side here. That I didn't zero it before, so I pulled back with the wire still in the LV, but the sensor across, zeroed it, went right back in. That's real time. That's exactly how much time it took. And the nice thing is, let's say that the gradient was there. They said, you know what, we really didn't do this patient a service yet. We need to post-dilate. I could add a CC right there on the table without pulling in the catheter setup. Is it the end of the world to have to do it? No. But as we move more and more towards value-based care, which actually is happening, if we're looking to improve our efficiencies, it really does make a difference. At least we've shown it in our lab. So one thing, I will say this, people who've done LV pacing a lot longer than I have, the common problem we have is what's the best way to ground the wire? I know we're coming up with more ways. I will just tell you this, that I would love to say I came up with it, but one of our surgeons said this is something they've been using hot off the press for about 50 years when you do cardiac surgery. Going in, what they do is they put this hook through the muscle. There's a wire with insulation around it with a little bit of braiding right there at the end. And so all you do, this is actually me, I put the suture through, I pull it through, I pull through till the braided part where the exposed wire is, and then I pull it back like that. You're grounded now. You're good for the case. We found that to be completely reliable, and you don't stick your hand inadvertently when you forget you have a needle in there. So this is just another case. This was a person who you can see, I won't belabor the hemos, but you can see they're pretty well compensated, has legitimate aortic stenosis, normal cardiac output, coronaries are nothing to write home about. But the patient had a BSA of 2.2 and a perimeter of 77. And so we were worried a little bit about the possibility of having some degree of patient prosthesis mismatch or something like that. And also you can see one other thing. This is a patient that when you normally look at this view, you don't see the extra cusp down here. So you can see the three-cusp coplanar was LEO 41, caudal 8. That's not exactly normal. Not the end of the world, but not normal. If you endorse the cusp overlap view, which we do strongly for deploying a self-expanding valve, you can see that this is not the normal view. What does it mean? You're going to need a wire that not just does what we talked about, but also can give you the support in a safe way. I think nobody would shy away from this access, but again, just showing that we've got some tortuosity. We're planning on using an Evolute system, and so we're going to need a wire that can accommodate this and do what I talked about. And so when we typically will look at our own measurements, we usually will use industry measurements as kind of an internal check. And we thought that based on our concerns, we thought this was most appropriate for self-expanding platform. The plan was to do a pre-dill, use a SavvyWire, and do an Evolute 29. And so again, we do pace during deployment. You can see here that obviously good capture using this, no issue with the wire. You can see the pressure sensor there. This is our cusp overlap view. We're deploying the valve, and this is the isolated non, just deploying up. No difficulty at all traversing the tortuosity I showed you, nor with this angle. The wire offered excellent support for that. You confirm the non, we're about 2 there. Flip it over to the left. We confirm the left, which if you really look at where it inserts is probably about 4. So 2 on the non, 4 on the left. We're very happy to drop this off. And we did. And right there at the time, we actually had a group of people watching while we did this case. And we said, hey, look at that. You see some ectopy here. That was actually the snapshot. I know what you're thinking. Wow, is that done from an iPhone? Yeah, of course it is. This is a real case we did. So yes, but you can see here, this was real time in our lab. You can see what the gradient was. You can see there's no gradient, which we didn't expect. And if you actually follow this out, you could immediately see there was no significant aortic insufficiency. But the group said, you know what, we'd really like you to prove that. We're not familiar with this wire right now. So we did. And by Seller's criteria, I would say that not one drop of dye went across the valve. So we were very happy with this result. But we already knew it when we looked at the hemodynamics right there. I'm getting kicked out here, I think. So the point of that was to say that not only were we so confident in the wire, but we were so confident that we actually did this for a live case for CRT. That just tells you that in a relatively short period of time, how comfortable we've become using this wire and how comfortable our labs have become as a workflow. So in conclusion, I can tell you that the SavvyWire with hemodynamic measurements gives continuous, accurate measurement and display of hemodynamic pressure. It delivers the gold standard of pressure measurement, and it minimizes exchanges. I can also tell you that, if in the era of getting faster, of getting more efficient, I can tell you that with a wire that really kind of like the Goldilocks story, the Safari wire we historically have loved. It sometimes is a little too soft. The Lunderquist is a little too tight, a little too stiff. This one's just right, if you will, with a very safe wire curve on it, and something that I was completely sold the first time I said, we're going to use the Savvy on this case, and my lab team went, yes. I couldn't believe it, but the actual efficiencies you get in addition to the hemodynamics really make a difference. So with that, happy to answer questions, and thank you very much. For sake of time, we can keep going if there's any questions. Excellent. All right.
Well, thank you very much for the invitation, and thank you for being here. I mean, I'm from Barcelona, so it's 9 hours difference. So for me, it's the middle of the day, but for you, quite early. So my name is Reguiero. I'm from Barcelona, and I will present this talk that is about changing the pacing paradigm during TAVI. So the first question is why? Why are we doing LB pacing? And to answer this question and many other questions of TAVI field, we have to go and see the TAVI revolution. So this is a slide that you will see plenty of time. You will know what it is. It's Dr. Reguiero with the first patient 20 years ago, and this is how it started. But now, there has been a huge increase in the number of patients that are being treated with TAVI. In the US, actually, the TAVI is the selected treatment for patients over 65-year-old, and in Europe is the same. So this increase in the number of patients has been backed by evidence, and we have now evidence that support this treatment, and is class 1 treatment for patients with severe aortic stenosis with different backgrounds. So the answer for the question goes into, and it goes very similar to what Dr. Harvey said, is adopting tools and techniques that can increase the safety and efficacy and minimize interventions. So during this period of time, we have all the time different questions, and sometimes you have questions and you try to prove it. And sometimes the ideas are good, sometimes are not. So for example, 2011, someone comes up with an idea of use adenosine to do an asystole to implant the valve. They prove this idea, this doesn't work, so they move on. But there are some ideas that actually stand up. So this idea of the LV pacing is not a new idea. The first report was done in 2013 with TAVI, but actually it's a bit, the idea comes back of 2009. This is the same concept, but without TAVI for balloon valvuloplasty. And this is based on a very old idea, actually, for pacing the patient with a coronary wire. And everything is the same concept. You are trying to minimize interventions to do the procedure more safely. So we take this idea, we move, we check it, and if it's okay, we adopt the idea, trying to minimize the interventions and improve the safety and efficacy of the procedure. Now we have evidence of LV pacing during TAVI, There are plenty of registries from Europe. So this is the first one that was published in 2016, 3 French centers, 125 patients, all of them with significant reduction of the pressure, 1 valve embolization, and 10% of patients who require crossover to implant a pacemaker during the procedure. Only 1 patient with tamponade that was 8 hours, diagnosed 8 hours after the procedure. Another study from Brighton, the UK, 208 patients, also 100% significant reduction of the pressure, 0 patients with valve embolization, and 4% of patients with crossover to right ventricular pacing. So in this study, it's 208 patients, so that's quite a number. But as you can see here, only 8 patients with SAPIEN. So there is a small registry, only 25 patients from Spain, but the point here is that all of these patients were treated with SAPIEN valve, and the results are the same. 100% of significant reduction of the pressure, 0% of valve embolization, no patients with cardiac tamponade, and 4% of crossover to right ventricular pacing. And there are more. We have the study from Oxford, we have from Birmingham in the UK, we also have data from Poland, and we have the data from the Netherlands, from the Erasmus Rotterdam Center. But we also have data from randomized clinical trials. So we have the EASY-TAVI trial. This is a trial in which the patients were randomized to right ventricular pacing versus left ventricular stimulation, 300 patients. And as you can see here, the authors demonstrated that LV stimulation can reduce procedure duration, fluoroscopy time, and cost of the procedure. And you can do that without increasing the adverse events. So as you can see here, 0% of patients with cardiac tamponade due to temporary pacing lead, because you don't have one. So good results. But actually, you can go further, and now we have this guide wire, because all the other studies were done using a Safari or different wires. But now, as you know, we have the SavvyWire. This is a pre-shaped, dedicated TAVI wire that has pacing capabilities. So it's a wire that is isolated very nicely with an orange plastic. So you can isolate the wire, and you have 2 spots here at the back end of the wire and at the middle of the wire to connect the pacing electrodes. And also, you have a pre-shaped wire to do the TAVI, but this pre-shaped curve is not isolated, so you can ensure that the pacing is correct. The feasibility study was published last year by Dr. Rodez and Ibrahim, 20 patients in Canada. They demonstrated the feasibility of this wire. And now we have the SAFE-TAVI trial. This is a trial that had the objective to evaluate the safety and efficacy of this wire using different platforms. The study was conducted in 8 European centers last year, 121 patients. And we're going to present the results of this trial later on at 10 a.m. So if you want to show up, we'll show the results there. But also we have a simultaneous publication in JACC Cardiovascular Intervention. So the abstract and the central figure of the image is available online. Okay, now I'm going to show a few tips and tricks to use the SavvyWire to pace the LV. For the sake of time, it's not going to be very detailed, but those are very important steps to ensure the safety of the procedure. First of all, you need to have all the equipment prepared before putting the wire inside the ventricle, because sometimes when you go with the Safari, actually just going in with the Safari and the patient presents with an AV block. So if you don't have anything prepared, you have to run. So just before putting the wire inside the ventricle, you need to have the grounding, the needle or whatever you're using, all the cables. You can see the SavvyWire here, the monitor, the pacing, everything ready in case that the patient goes with an AV block, so you can respond very quickly. The main advantage of this wire is that it's isolated, so you don't have to put any catheter or anything. So you just put the wire, and you can immediately pace the patient. So it's very, very safe. Once you go with the wire, it's also important to ensure that the wire is free it's not untangled, and that it's well opposed into the wall of the ventricle, because with this way you can ensure that the pacing is going to be correct. So as you can see here, you can see that the wire is not in the mitral apparatus, and it's going very, very nicely into the apex of the left ventricle. Once you are happy with the position, if you are not happy, you just remove the wire and use a pigtail or whatever to be sure that the wire is okay. Then you connect the electrodes, and there are plenty of different ways to do this. One, I actually haven't heard about that one, and I will use it. It's a really nice one, because the standard way is to put a needle, and you are always afraid of having a needle and having a bit of bleeding and going to press the groin, and then you'll have an issue there. But actually, most of the people are doing that. If you don't want to have a needle, another option would be to put directly the alligator into the skin of the patient, and you can do that in the same axis of the TAVI. I mean, here the axis is a bit big, just to put the alligator, but that's another option. There are two more options. One is to use an electrocautery plate to isolate or to ground the wire. And recently, there has been a publication, a report, to connect a wire inside the pigtail. So the pigtail is touching the aorta, and you can connect the grounding to the wire inside the pigtail. The problem there is that you'll have to put a 2E valve to inject through the pigtail. So it's a bit more, I mean, you can do whatever you want, but you have to ensure that the pacing is correct. So before implanting the valve, you go on and put the pacemaker setup. Usually, it depends the heart rate if you are implanting a self-expanding or balloon expandable valve, but you go in between 180 or 200. The output, we recommend to go to the highest output, but if you want to measure the threshold, then at the moment that the patient lost capture, for example, it's 5, then you'll have to double this value to be sure. But it's safer actually to go to 20 or 25, depending on the pacemaker capacities. And also, you need to do asynchronous pacing. So before implanting the valve, you have to do a pacing test. So here you can see that we are ready to implant the valve. We haven't crossed the valve, but still we can do the pacing test. And you're looking at the live breath pressure, which is in the pigtail, and the pressure inside the ventricle. And you can see that there is a nice pressure drop with the pacing test, that the pacing test is stable, and you can see here that the pressure drops below 50. So if you're happy with that, then you can move on to do the valve implant. And two very important things here. As you can see here, my hand is holding the wire, because one of the most important things during this time of procedure is to hold the wire steady here, because sometimes when you implant the valve, the wire can move a little bit. So you have to put the hand on the wire and ensure that the wire is placed properly. And the other main advantage of this wire is that you can actually see the pressure inside the ventricle while you are doing pacing. So the red line is the pigtail, but you can see here the white line inside the ventricle. The pressure is below 50, so you can deploy the valve very, very safely. So I would say to conclude that LV pacing is not changing the pacing paradigm. Actually, LV pacing is adopting the TAVI paradigm. So we need to minimize intervention and increase patient safety and security. Thank you very much.
That was an excellent presentation. You showed a couple things there that really were kind of generating thoughts. One, I think the data you showed looking at the U.S. population with I think Harry Dowerman presented that, and it was pretty shocking to see that that you know the guidelines say 65% or 65 or higher, but I have yet to meet a patient who's read the guidelines. Some of my colleagues as well, and so the fact is that that creep is there because we believe in it, and the patients want it, and even our surgeons agree with it, and so it just again reiterates the fact of how important it is that good enough isn't good enough, right?
Yeah.
So.
Okay. Thank you.
Good morning. Thank you for having me. Samuel Horr, I'm an interventional cardiologist, structural heart cardiologist in Nashville, Tennessee, at TriStar Centennial, which is a HCA facility. So my role today is to go over some cases and have a busy clinical practice and how Savvy has really impacted that clinical practice for me, how it's increased efficiency and improved patient outcomes. These are my disclosures. So for me, I like to put Savvy into 3 buckets. So when I'm thinking about if I'm going to adopt a new technology, it has to do a few things. It has to increase efficiency, it has to improve or not at least detract from clinical care, and it has to improve outcomes. So for me, trying to sell how to get this wire into my hospital, it does reduce the number of pieces of equipment that you need. It replaces the traditional TAVI wire, the Safari or the Lunderquist or the extra stiff, whatever you use. It gets rid of a transducer, it gets rid of a venous access kit, it gets rid of an RV pacing wire, and a closure device, if you use it, it also decreases the amount of time, so you don't have to hold pressure out in your recovery or your fellow, whoever holds pressure for you. Increases efficiency, so we're a place that does a lot of hemodynamics. We do pre-hemodynamics, post-hemodynamics, and we take a lot of stock into what that shows. For us, it reduces time as we're turning over rooms to set up transducers. It gets rid of, again, a pacing wire, which reduces the amount of time you have to be on fluoroscopy. And so I'm glad you showed that fluoroscopy slide where it actually reduced the amount of time. We've actually seen that quite a bit as well. And then we minimize exchanges. So when we deploy a valve, we can actually get instant hemodynamics to know whether I need to post-dilate that valve or not without having to take the delivery system out, put a pigtail catheter in, measure pressures, get the echosonographer in. I have a lot of hints about what that echo is going to show without ever having to do all those exchanges. And I think the other thing it does is it minimizes complications. So in my practice, at least, the 2 most common complications are going to be access site complications and then pericardial fusions. And most always the pericardial fusion is due to the RV pacing wire. And we've done a lot of things to try to change that, but haven't really reduced our pericardial fusions until we got Savvy. And so since we've had Savvy, we've had no pericardial fusions. And that's a direct thing that we've seen and can go back to our administration to say, this is how we're improving patient care. So, when you first start out with any new technology, you want to start with a relatively straightforward case. And so this is how we position it in the ventricle, just like we mentioned before. You want to make sure it's all the way out in the apex. It's a very supportive wire. It allows us to navigate very tortuous anatomy, very complex anatomy, horizontal, as you can see here, slightly horizontal. I would consider this a relatively straightforward case. You see that the wire provides enough support. This is the deployment of the valve, and what you notice is that as we push forward on the wire, the valve does come up a little bit, but the wire is supportive enough and it gives us enough time with the reliable pacing that we're able to advance that valve into appropriate position and deploy without missing a beat. And I think that proved to me in the first case that we did that this is a wire that I think is going to change the way I practice. So of course, when you first start out with a new technology, you do the easy cases, but then we're all very interested in, so immediately you start moving to more complex anatomy. And I think what I was surprised about when I used this is that even in complex anatomy, it's supportive. And so this is a patient. This is one of our early cases as well. It's a severe calcified valve. You see here we're planning to do a 23 balloon expandable valve. You see the STJ is not that friendly. It's a little bit small. It's circumferential calcium. The aorta, which you can see is tortuous, and you'll see in the next slide, it's actually a little bit even more tortuous than it looked like in the CT scan. So despite all those challenges, you can see here our pigtail catheter, as it goes down the descending aorta, is taking a large twist. And despite that, you see that we have great support, not a single concern at all in terms of support of the wire or missing pacing with a pretty standard deployment, which I think with some wires we would have struggled. We would have had to use either a very supportive wire to get through this anatomy and maybe compromised on the ability to be coaxial when you use a very supportive wire, or use a less supportive wire and lose the ability to push and pull the valve as you need to make those small changes. This is that same case. So this is early. This was a beautiful example of how we were able to take a patient with very severe aortic stenosis. You see a peak-to-peak gradient of over 70. And take that patient and give them a great result with a peak-to-peak over 3. And we thought this was a very good result in a 23 balloon expandable valve. So I think if you ask me where is this wire best, I would say valve and valve, right? So as minimalistic TAVR becomes a thing, we want to minimize what we do. Valve and valve is perfect. So this is a case in which you can have literally one single access. Radial, if you believe in cerebral protection device, but otherwise it's a single access procedure. You have all the things you need. You have hemodynamics, you have pacing, and you have valve deployment in one arterial access. And so, as I said, the most common complication for us is peripheral complications. And so by minimizing arterial access, minimizing venous access, it definitely has made this safer for us. So this is a valve and valve and an Epic super valve. We deployed the valve, and I don't show the whole thing. I forgot to save it. We did it under fluoro rather than a cine, but we're actually able to deploy this valve out of a valve. You see it's very restricted, and then we went on to frac the valve, all while using one access point. With the instant hemodynamics, we were able to see the drop in gradient and have a very good result.
That's pretty cool.
So again, we keep getting a little bit more challenging. I start, get comfortable with the valve, get comfortable with the wire, and then start pushing. So this is a patient with a bicuspid valve. You can see there's fusion between the non and the right with a very heavy calcium, very heavy calcified throughout the arch, and the annulus also had a significant amount of calcium with a lot of MAC. And this is the 78-year-old gentleman who, because of his peripheral vascular disease and other comorbidities, was not a surgical candidate. So despite that annulus that you can see on the right, we thought he was appropriate for a transcatheter. So you can see here, this is our balloon valvuloplasty. That incision was displaced. It was a 26 valve with large sinuses. And so we decided a balloon valvuloplasty. It was a bicuspid, all with very good support with the SavvyWire. And then we felt that even though there was annular calcium, that we thought a balloon expandable with the skirt would be a little safer here. And what you see in this deployment is it's a good deployment. What you'll see is on the left side, there's actually some underexpansion and some recoil, all from that calcium right where it extends into the annulus. And so what we did was we immediately pulled that catheter back. And again, I wish I saved a lot of these pictures. I think about it afterward. Yeah. But immediately what we saw was that the diastolic pressures were meeting on the SavvyWire. And so without anything, we just pulled the catheter back, pulled the balloon out of the valve. You immediately see the diastolic pressures are equal. And the gentleman has very severe peripheral vascular disease. So the question you bring up is this low diastolic due to peripheral vascular disease, or is it due to aortic regurgitation? But knowing that annulus was severely calcified, our first guess was, well, I think this is probably aortic regurgitation. So immediately we do an echocardiogram, and this shows it's at least mild PVL, but I would argue that if we did a TEE, it was probably more moderate, and the hemodynamics suggested that it was more moderate. So without taking our delivery catheter back, we were able to add a CC to the delivery system, post-dilate the valve. Again, you can see how it's underexpanded and sort of asymmetrically expanded previously, but by adding a CC, quick post-dilation, getting rid of the recoil, allowing better expansion, we were able to then quickly see the hemodynamics improved and there's no AR. And so I think this improved efficiency. This would have taken us an extra 10 minutes to get an echocardiogram in there, maybe do an LV gram or do an aortogram, maybe do pressure again with a pigtail catheter, but we were able to quickly diagnose the problem and give the patient a result. And so he was 78, and other than a few comorbidities, my expectation is he was going to live a long time, and I wanted to give him the best hemodynamic result while minimizing AR. And the Savvy was able to do that for me and be very efficient. So not only the tortuous aortas and the calcified aortas, you want to make sure that you have good support through the peripheral system. And so we frequently are pushing the envelope on what we can do with transfemoral access. And so this is a patient with pretty severe peripheral vascular disease. The left was worse, which I didn't show here, but the right side we thought was a reasonable access, very small but calcified. We were able to do lithotripsy, open up a good channel, and despite that, the valve, again, very good support through the anatomy. So for me, how I use Savvy in my practice is that it's streamlined. So it makes it more efficient. I don't have to take the time. We have lower radiation dose. We don't have to put an extra venous line in. I don't have fellows in my practice, so if it's holding pressure, it's going to be me, or it's going to be a nurse that may or may not be a traveler I may not have met, don't know how often they've held pressure. So if I can minimize access, it is going to minimize my complications. It doesn't compromise. It gives you the support of a good wire, but it also gives you all the hemodynamics that you want. We were able to test for AR, as I showed that case right away. And then we use it in a couple of other scenarios that as we are looking at AS and moderate AS and evaluating the cath lab, frequently, especially as the dual lumen pigtail went away, and who knows when it'll go away again, we frequently use that for AS assessment in the cath lab. And so overall, I would say it's a great adoption into my practice.
Outstanding. That was also outstanding. I tell you, I'm used to being the guy who shows the crazy cases. You didn't pull any punches on those. I like what you said too, in that I think we have fairly similar practices. I've been to your practice before as well, and I remember it was kind of radical that we were going to do 6 cases in a day, which doesn't seem so crazy now at all. But if you're looking at trying, the gap for us between 6 to 8 was actually considerable, because that was where if one of them went kind of long and whatever else, but if you take the 7 minutes here and the 12 minutes here and the other, that actually added up to now we can consistently do 7 to 8 just because of that. And so it matters. So great talk.
All right, so good morning, everyone. So I'm glad to join this brunch symposium. Which was a breakfast. But, I'm very happy actually to share my thought about the field of TAVR and the AS in general. I've been a strong adopter of the SavvyWire as soon as it came. I was lucky to be part of the development, and clearly changed my practice in terms of efficiency. We really, like you, James, went from 6, 8 to 10, sometimes 12 TAVR a day in 2 rooms. Still finish at 4 p.m. So I think this is something that was key to minimize access and complications. So really SavvyWire, no compromise, and improve efficiency. So I was supposed to kick the session, but I think, James, you did amazing. So you get promoted to moderator. Congratulations, you all did a good job. So I want to share my thought about the trend in aortic stenosis and how it's going to impact our volume. Obviously, I'm a little biased because I'm part of the leadership of those 2 very important trials. One early TAVR, which is finished enrollment with severe aortic stenosis and no symptoms, almost 1,000 patients randomized to TAVR versus surveillance, and clearly believe that it's going to be presented next year at TCT, but clearly believe it's going to change one way or the other the management of aortic stenosis. The other one, which is equally or even more excited, is we go to uncharted territory of moderate aortic stenosis, and this is the PROGRESS trial. There's other trials also out there, but the PROGRESS trial is for Edwards SAPIEN valve, assessing moderate AS patient with TAVR versus clinical surveillance. So really pushing the boundaries. So I think those 2 trials will be very, very important. Again, will change the way we manage patients with AS, and will probably bring a lot of TAVR in our cath lab or OR. So please stay tuned. Where I believe the field is very, very exciting is really leaflet modification. So we do a lot of TAVR in very complex anatomy like we saw. There's a lot of calcium. The valve may be underexpanded. So I think we're going to start to cut those leaflets, crack those leaflets. There's company out there such as Picardia that may crack the valve and maybe increase mobility of the leaflet. Will probably result in better expansion of the valve and potentially better durability. There's splitting of the leaflet. We know valve in valve would be very common as those TAVR we did in 2010 come back. So we're going to have to split the leaflet to avoid coronary occlusion with a shortcut device. So all those techniques will require continuous monitoring of your outcome, of your result, and I think the SavvyWire will be perfect for those cases, and that's the future. The next one, the last one, is really excision medical, which actually will remove piece of the leaflet, really play like a surgeon and do like a surgeon. So really, I think we will have a need to monitoring constantly, invasively, precisely the result, the gradient, the AI. So I think the SavvyWire would be perfect for those trends. I'm working with a company, Picardia, to try to model what will be the growth of TAVR in the future. And this is really the growth of the TAV in TAV and the growth in TAV in SAV. So it's funny because for the last 6 months ago, I didn't have a lot of TAVR failure. And magically, I met with those people and start to come now, we have 1 a week, an old TAVR that failed. Wow. And what we see since today, so today when you look at the TVT registry, there may be about barely 1,000 TAV in TAV that we do. But this market is supposed to increase by 6-fold almost every year because of the demography of the patient, the TAVI we did. So we do 700 TAVI at Morristown. So they're going to come back at some point. Maybe not to me because they're a little bit mad, but maybe to you. So they will come back sooner and later. So we're going to have a growth of the TAV and TAV, a growth in TAV and SAV, with a growth of TAVR in general. So I think to be efficient, and to your point, the TAV and TAV and TAV and SAV, I think this is where SavvyWire shine more than any other place. So we're going to have a growth of this market, and that's going to be, like I said, a six-fold growth until 2035. But we start to see those cases coming back, and they're complex. So the SavvyWire, more than a wire, I was not a LV pacing guy before I used the SavvyWire. I was not taking the hemodynamic, but since this thing come, I do both now very efficiently. So this is really the first wire with a capacity to have a sensor guide solution designed to optimize TAVR. I really like the characteristic of the wire. They made a good job to make it stiff enough, but not stiff enough. The distribution of the stiffness on the shaft is beautiful. The fact that there's a pressure right away, this is just connect and disconnect the sensor at the back, very good. And the pacer is really the only one which actually has dedicated LV pacing wire. So if you're still shaving your Confida or your Safari with the threshold of 10, 15, sometimes 20, this has a threshold of 2. I've been testing that all the time. Very, very good. And what I like about the pacing is you really control the pacing and the efficiency of the pacing. You have the left hand on the sheet and the catheter, the right hand on the wire, and you really control the LV pacing. When you have an RV pacer, you never put your hands on the RV pacing. The RV pacing is floating around, way, way, way less stable than the LV pacing, especially with the SavvyWire. So I believe it's clearly an improvement in efficiency and in safety. This is the beast. So you have this wire, typical O35 with a very nice orange color to get mist. Pre-shaped, there's a small and extra small. I use the extra small in maybe 80% of the case. I use the small for the BAV and also for large LV. And really the key of this wire is the proprietary technology of the sensor, the optical sensor, the Fidela sensor, which is very, very reliable. Actually, the sensor that is used for Impella, so can literally be accurate for 90 days, 6 months. So there's no drift. It's very accurate. So very, very strong technology. This is, you saw this in many presentations, so I have a very great display of the pressure, the gradient, peak to peak, the mean, and LVDP. So very useful after a case. You can assess if the patient is stable or not. And I learned a lot actually yesterday, Monday listening to you, James, really measuring the LVDP to see if the patient is an acute heart failure or not, and maybe changing the billing and the coding in US, which is, could be important. So I think this is a very good tool for many regards actually. In the early experience, we tried it with all the valve and all the complexity and really performing very well, and especially with a more complex device such as Evolute 34, where sometimes it's a little bit unstable. This has been a key player to improve deliverability and stability of the implant. So really a superior wire compared to the competitor. Something which is very exciting, and we are still working on developing, but this is available in Canada, the aortic regurgitation index. And the dream is really to have a wire where at the end of the case or before and after the case, you have the pressure and then you have your AR and you're done. Really play like a single wire procedure. And I think this thing could be very useful, valve in valve, but also when we do bicuspid. So those patients, sometimes we have to pre-dilate, we have to post-dilate. I talk about the leaflet modification. You can see that those could be a very useful tool when you split a leaflet or you modify a leaflet. So I think this tool, the need of this tool will grow with time. So I think in conclusion, this is a wire which has a very, very good property. The performance for valve implantation is unparalleled. The stiffness is great, very safe, and this is what I will call a third generation wire. I trained in 2007, and I can't believe I say that, but 16 years ago, where I was shaping my implants and kinking this thing. It was all the heart of shaping a wire. Now we're past those time. We have a dedicated wire with a very good performance. We used to do two pigtail, and actually I was not doing two pigtail. Why? Because it was taking time. Now I just connect and have it, so I'm impatient by nature. So I think this thing is really, really a game changer for the hemodynamic and in the cath lab. And the pacing, reliable. I think, you know, for me, when you go to the SavvyWire, you don't go back to the RV pacing. When I see some people with RV pacing, I say this is so 2007. So you have to be contemporary, save money, and be more efficient. So for me, this is a very exciting technology, and I cannot say enough good thing about it. So thank you.
As always, Philippe, every time you speak, I learn something. This one I didn't want to learn. I was really hoping I was going to retire before the TAV and TAV wave happened, and it's going to land right in our laps, isn't it? So it couldn't be better timing for the wire, actually. Those are sobering statistics.
Well, I think, you know, this is what we see. Obviously, those cases will be complex, you know, whether it's going to be thrombosed, whether it's going to be restenosis or calcified, they're going to be complex. And if you do TAVR the first time, they're not going to go for surgery the second time. You know,
There's an editorial on that, and I saw that looking at surgery after TAVR, and actually it was Mike Reardon who read the editorial, and the title of the editorial was "Breaking Up is Hard to Do." So it tells you how much surgeons like taking out TAVR valves as well. So you're exactly right. We're going to be doing a lot of TAV and TAV as it comes forward.
Yeah. So, you know, I was listening to your talk about the RV perf, and for me, it's funny because a lot of time, small women, tortuous vessel, you struggle with a pacemaker. We used to do a lot of TE, and it's funny because sometimes I think people call RV perf, but I think a lot of time it's also RA perf. When you struggle, because you know, when we do transeptal with all those cases, always the RA, and it's very fragile. Posterior wall, you push, you don't know where you are, and sometimes it could take. It's never trivial a RV pacemaker when you have tortuous vein. I used to use a long sheet because when I had my wire, I was tired to go in this little small branch, and when I saw my surgeon pushing the pacemaker in the small branch in the middle, I'm like, so I think that you eliminate this part actually. Yeah.
So I agree. I think that for us, we have a lot of older, smaller women, people on steroids, people where they're very fragile, the RA and RV. And I think the other thing that we sometimes see with the RV pacing is that I live in Tennessee, with the BMI is quite high, and you get these people that we try to do minimalistic TAVR, we're trying to do conscious sedation, and at the exact wrong time, they obstruct. Then they take a deep breath, the pacemaker moves, and we've taken that variability out of it completely with LV pacing.
Yeah, another thing is that, I mean, I do all the time LV pacing, but there are people who is not there yet, and one of the things that they say is that they're a bit afraid of having to put LV pacing at the middle of the procedure, but actually with this wire, you know, you can take all the time that you want because the pacing with the wire, while you do whatever you want, is very, very stable. So you don't have to run. You just put the wire there, connect the pace, and ask for the echo or whatever you want. So it's very safe to do the crossover. And I think this is a beautiful part of the wire also.
Go ahead. I was going to ask in that, I know that a lot of operators in Europe had adopted doing LV pacing long before the United States.
Yeah.
And the question I had was, were you doing that before this wire?
Not consistently,
Okay.
but now I changed completely.
Yeah, I ask it because, you know, obviously a lot of people have shown you can do it, and then the question comes into the logistics of, but then what about when you pull your catheter back and you've lost the insulation,
Yeah.
and then, you know, we deal with a numbers game, and that, you know, how much is enough of a difference between your capture threshold? And so I was just curious about operators who'd done it beforehand, because I maybe to a fault, I have an engineering background, and I was like, that level of risk was just never tolerable to me until we actually had a dedicated wire. And if you've ever tried Basilica, you know, with like a telltale wire versus kind of doing and you can do it, but it's kind of one of those that you can kind of do it. And so anyway, I was just very curious from the perspective of people who've done it.
Yeah, I mean, we actually don't have the wire commercially now in Europe because still doesn't have, it will come, but so we are doing the LV pacing with the Safari.
Sure.
We did during the trial with the SavvyWire, but still with the Safari, you know, you are very confident and you don't have any issue. And that reason that the RV pacing is moving a lot, it's actually very, very very, very true. You know, it's kind of very risky situation. You see the catheter moving, the people pushing the catheter. So it's early pacing is not actually that safe.
Yeah, and you know, those patients that come with right bundle and left bundle, we used to have a neckline and we used to use a temporary pacemaker, but I had a couple of times where for, you know, just, let's put a TVP overnight even if there's no, nothing happened, and when you pull the pacemaker next morning, there's an effusion, and there's a tamponade, and this is a disaster. But so I think we learn to be minimalistic. It's okay maybe to have a neckline if you're at risk, so you're going to facilitate your crossover. But many situations where the patient is complete AV block, and after 2-3 minutes, the block resolves.
That's right.
So I think this is, to your point, I think that's changed completely our practice. And this instability in the RV is real. We did a couple of LV pacing with Confida and Safari, but it was always, I was always nervous. I would have like, let's go, and I was like, okay, let's go down with the balloon, let's stop, like, you know, counting to 5, like, not count to 3, you know, so, but, so it's, the level of confidence is 0, and in US, in the climate of lawsuit and everything, I can't understand people that use undedicated, not FDA-approved device to pace, and not run the risk of, like, what's going on, because you're going to get burned in the court. You know?
And I can say that because I've used both with the same amount of patients, you know. And the tranquility and the so yeah, it's not the same, but will change for sure when we have it. Yeah.
Yeah. So I'm a big Sapien guy. So James, before you go to the airport, what about Evolute or when the final release, when you pull the wire? How do you manage the SavvyWire if you want to pace or don't want to pace? Or
So you're exactly right, and that was, as the truth is, and I've heard counter thoughts either way when people who were original skeptics of LV pacing, like I was originally, and saying like, well, I'd rather do it in Evolutes instead of Edwards because of the absolute dependence on pacing during an Edwards. And the reality is, we were the opposite way for the reason you said. We became, I mean, the data says it, and once you use it, you realize, wow, this is a really reliable pacing. So we actually got to where we would do basically all of our Edwards with it. And the last stronghold for me was with the Evolutes. And so a couple things, two things. As you know, when we do we're pretty big endorsers, we are strong endorsers of the cusp overlap technique. And on final release, and I will tell you, being a proctor for that trial, that the single most contested step was the use of the Lunderquist wire. And that's with good reason, right? Because it's a great wire, but like, you know, as Spider-Man says, with great strength comes great responsibility. And so I was hesitant with that. And so we started trying it. And there's two things, because with that wire, with the Lunderquist, when you're going from 80% to final release, you need to pull the wire back a little bit so that as you know, so that the nose cone, if you have inadvertent tension, doesn't jump back and catch the cage. We found two things. One is with this wire, we actually checked. We actually pulled back, and it's not the same as in the apex. It actually will continue to capture like almost every time. If you didn't, you could still come back, release it kind of easy if you actually are in heart block and go right back in and pace. But what we've also found is that because the shape is like a Safari, but the stiffness is not, that really I often don't have to pull the wire back because it keeps the nose cone in a position where I'm not at risk of it diving back. That was the biggest change for me, as I realized I can adapt my technique because the wire does things that the Lunderquist didn't do. So that's why I showed the second case was a say, and we're confident with an Evolute as well now too. So.
Yeah, we did half of the cases also with Evolute, Sapien Evolute on the trial.
I apologize.
Yeah, thank you so much.
Thank you so much. Wish I could stay for the discussion.
So you actually said that the stiffness of the wire is perfect because you have a stiff wire when in the place that you want to have it, you know. But actually, at the end of the wire, it's you don't have to remove it completely to center the nose cone, so you can still pace while removing a little bit without putting the wire just in the middle, losing capture. So you can do it. Yeah.
So one quick question about the workflow. So where I land, I tried different way, 0 before, 0 after, or doing before and after. So I land in a place where I do my TAVR, and after, when the valve is implanted, especially with the new wire, with the sensor, it's a little bit more proximal. I pull, I verify equalization, and I push, and that's it. It's so efficient. It literally doesn't change anything. And sometimes I can just look visually all right, it's equal. I don't even have to zero. And then I push, and I can visually see my gradient. So, and I always like to use one beat average because I see it right away. I don't have to wait for sign beat. What is your technique? What is your workflow that you adopted?
That's exactly the same thing. So we, exactly the same as you. As soon as we deploy, we pull the delivery system back, immediately check to make sure it's equalized. Don't even have to equalize button if if it's visually good, push it right back in, have immediate results, so that we can act on it without having to do all of these exchanges.
Yeah, and we do the same because actually if you have a little bit of drift that usually you don't, it won't change anything at the beginning of the procedure, So you're gonna go from a gradient of 45 to 40 or 39, but actually at the end of the procedure you want to be a bit more precise. So that's why we do the equalization after.
And I think, you showed the slide of the age and the number of TAVR, and I think that's even more important as we go to these patients who are demanding TAVR in their early 60s. The patients wanted that we really optimize hemodynamics to try to decrease the number that you showed of TAVI and TAVI coming back.
Yeah. Are you surprised about this? Is something you see in your practice, the TAV and TAV slowly coming, or not yet?
Very slowly, because,
Very slowly.
I mean, the volumes that you have here are kind of amazing. We started to do more and more TAVI, but like 3 years ago. It was when actually exploded. So we'll see it in the future, but now we have done only a few cases. Yeah. We'll have to learn from you, and we have the problem solved once you struggle with it.
What about you in the US? Do you see slowly dripping?
Slowly, the people we tend to see to come back, at least the early ones, have all been small valve, PPM, that you wonder if we missed some hemodynamic optimization before because of we weren't always checking.
That's a good point. All right, any question from the audience? There's microphone there.
Hi, good morning.
There's one guy in the back. He reached 1 second before.
Yeah, just a quick question. Can you guys talk about the economics or the cost trade-offs of using the SavvyWire?
So I work in a healthcare system that's very attuned to that, and I would say the thing that we at least made an argument, again, it gets rid of an LV wire, it gets rid of a pacemaker, gets rid of an access point, and so a few things. You can actually use this to, whether or not it's on label to use, you can actually use it as your sheath wire as well. So if you use a different wire for your sheath access, you can actually use this. It's stiff enough and supported enough, even if in severe PAD. So you can get rid of enough equipment that it's relatively cost neutral. And then the next thing we showed was we decreased our complication rate and our time efficiency in which we could do more cases. And so between all of those arguments, it's actually cost savings, I think, in the end.
Yeah, I will echo that. I think, the material you say, but one of the key points for me, it's really improved my quality of life. And, it's going to remove all the annoyance and the pain point of the procedure. And once you start to do this and you start to be efficient with the SavvyWire, to stick a vein, to bring the pacemaker, it's really annoying. And it's, we're getting pretty fast to do TAVR, and, sometimes you do a TAVR in 20 minutes. But, if you do a TAVR in 30 minutes instead of 20 minutes and you multiply by 10 times, you're still going to do the same amount of case, but the nurse will go home at 6 and not at 4. And I think this is this notion, let's be efficient. Yes, you can squeeze 1 or 2 more cases, but most of the time is let's go home earlier. And I think it's the quality of life, is the efficiency of the procedure. Yes, if you want to do 14 TAVR a day, you could, but I think it's also the flow, the safety of the patient. So I think that's also the reason why. Yeah. Final question? Yeah.
Oh, thank you. Could you comment about the possibility of interference of the wire once you left the TAVI prosthesis? Then you want to see if there is regurgitation, but often I observe that the wire is sticking a leaflet.
Pinning.
So then I change with a pigtail. And if you have any trick or comment with this new wire.
So we did a lot of TEE, especially at the beginning of the experience. So, we were like just trying and want to see the outcome. You're right. If you pin the leaflet deep in the LV, in the apex, it's going to pin a leaflet, probably like any stiff wire. So literally, I'm getting very good now to just recognize, oh, the profile of pressure, and I pull, and it's most of the time resolve the issue. So I think this is an issue with all the stiff wire that you have to be aware, and most of the time is resolved by centralizing the wire in the LVOT. I don't know, what is your experience with that?
Yeah, the same, because it's kind of soft at the tip. So if you remove it a little bit, it usually works well. Yeah.
And one of the modifications of the second version of the SavvyWire is they put the marker more proximal, so that's allow you to have more soft part in the LV. So yeah.
Agree. I showed the case that we knew there was AR based on assessment, but the question was, were we just pinning it up in the leaflet? And you noticed in the video, I pulled it back a little bit, and then but we did a quick echo to prove it to ourselves, because we had that same exact question. But by pulling it back, you tend to get rid of that central AR. And then the final picture I showed was an aortogram with the wire still across, and you see that there's no even central AI there.
All right, so with this, we're going to close the session. I want to thank my co-presenter, and thank you so much for coming so early. And the SavvyWire, it's a great tool, and I think it's going to be very useful in the future. So thank you so much.